Good evening, everyone. Thanks for joining us for the Julia Agru Endometriosis Centre No Endo series on endometriosis and pelvic floor problems part 2. Thanks for everyone who joined us for part 1, and this is the second part where we've got Dr. Samantha Mooney joining us to give us all of her tips and tricks and information and strategies of pelvic floor and endometriosis. I'd like to begin with an acknowledgement of country. We know that Epworth Healthcare acknowledges the people of the Kulin Nations and the traditional custodians of the land upon which we work and care for our patients. And we honour the unique and continued spiritual connection that Aboriginal Australians and Torres Strait Islander peoples have to land, waters and cultures. By introduction, I'm Kate Tyson. I'm the Director of the Julia Agru Endometriosis Centre, and you don't need to hear more about me. But Sam Mooney is a gynaecologist whose clinical interests include pelvic pain, endometriosis and management of benign pelvic masses and heavy menstrual bleeding. She's an accredited level 6 laparoscopic surgeon. Sam finds joy in providing patient-focused and evidence-based care to women with a range of gynaecological concerns. I know lots of other things about Sam, but this is her professional bio. Sam is an active clinical researcher with interest in pelvic pain and endometriosis and hysteroscopic techniques in surgical education. I've got to move on to the next slide, maybe somehow. I've got a small technical glitch. Excellent. A couple of housekeeping activities. So at Epworth, we're proudly inclusive. We acknowledge that not everyone with endo identifies as female. We aim to avoid the use of the term women in the webinar, and we acknowledge that non-binary, gender diverse and intersex people, and in rare case cis males, can also suffer from endometriosis. We hope that you have questions during the webinar, and we want you to drop the relevant questions into the chat box as we go. If it's appropriate, we'll bring them up at the time and we can chat together. Otherwise, we'll get to it at the end of the discussion time if we have time. This session is recorded, lucky us. So all registrants will be emailed a copy of the recording once it's available, and it's also available online on our website later this week. So now I'm going to move over to Dr. Mooney's presentation, and she will wow you all with everything you need to know about managing endo. Stop sharing there, share the new screen, and then we've got, oops. Okay, 1 second, I've done that wrong.
I'm glad Kate's driving this, or we would be a long way behind already.
Here we go. That should be loading. Get that out of the way here. Since it's down.
Just click into on here. Because interviewing.
Mouse, yeah, there you go. The mouse go back that way with the mouse, and then down to the screen. We have 3 screens with the mouse moving.
I was a bit fussy on how the screen got set up, and I made it more the confusing for both of us. That's right. We'll run it as is. That's fine. I'm just not sure how that advance. No, it's not going to advance. So it's not in.
If you put the mouse back on that screen, if you can, yeah. On this one, yeah. Do you want me to do that one separately for you?
Yeah, I just can't work out why I don't get the view. Don't worry. Well, it's a pleasure and I guess a privilege to be invited to speak to such a wide audience on a topic that's become quite close to home. For me being a gynaecologist, and I think pelvic pain has become the most common reason that patients would come to see me, and no doubt Kate and many of the other gynaecologists on the there's going to be a pain on the talk 2 shakes while we try and sort that out. I'll drive both. There we go. A couple of disclosures. I've got a little bit of funding from Hologic for a fellowship, and I have also put that I'm a NAGES trained gynaecologist, which comes with a little bit of a surgical sway. But I think we're moving much more towards viewing the holistic nature of pelvic pain, the multifactorial causes, and I hope that's why I was asked to step everyone through the medical management of pelvic pain today. Kate's given me a very kind introduction. Essentially, I'm a general obstetrician gynaecologist with a particular interest in endometriosis, infertility and pelvic pain, and growing an interest more in pelvic pain just due to the sheer numbers of people that suffer from this condition every day, every month, every year. I understand that our audience today is quite varied. We have patients with persistent pelvic pain, loved ones, support people, patients, as well as healthcare providers. And I understand too that we have previously gone through as a topic pelvic pain management at a physiotherapy level, and I'm moving to look at the medications that we use for this condition. I'm speaking to the converted, I'm aware tonight, in terms of the problem of persistent pelvic pain. Now, the current definition that comes out of ACOG is pain that is present more than 6 months, predominantly in the pelvis, so below the belly button, and is sufficient severity. I find this quite a strange statement, but sufficient severity to cause functional disability or lead to medical care, which is the patients that we're seeing. And it's often associated with symptoms indicating gynecologic but other organs that persist in the pelvis as well, so urinary tract, bowel, and becoming more and more important and recognised is the pelvic floor musculature. I'm just going to pause to count. I'm just going to see if it's going to be possible, because I'm going to flick between the two consistently.
Yep, and because you've got notes on this one that are useful.
That's all right. I can. The audience doesn't mind me.
No, I'm not
going to.
Yeah.
Is it going to be possible?
Yep.
Okay.
But I'm going to swap sides with you so I can drive it for you.
Sorry, everybody on the audience. There you go. Musical chairs. You haven't seen that before. All right. So, the incidence of pelvic pain is becoming, or persistent pelvic pain is becoming, more and more understood, and it's thought that at least 1 in 10 and probably as high as 1 in 4 adults assigned female at birth will have an instance of persistent pelvic pain throughout their reproductive or postmenopausal years, with great impacts on their quality of life. It is now the most common reason that we would see patients in an outpatient gynecological service, and is an indication for at least 40% of laparoscopic surgeries. You would all be very aware of the far-reaching physical, social, emotional and economic consequences of persistent pelvic pain, and I've just popped on there the current estimates in the Endoactive website that quotes the estimated costs of endometriosis as a leading cause of pelvic pain, but not the only cause. So if endometriosis is one of the causes, then the costs are even higher for if we include all the other causes of persistent pelvic pain. So why is it important, and why? So that's why it's important. Why is it persistent? It's persistent because whilst it can originate from organs, uterus, ovaries, vagina, bladder, intestines, nerves within the pelvis, there are other pathologies or other things that we are becoming well aware on how it then persists. It doesn't exist usually as a single disease entity, but involves multiple organ systems that are cross-related, and then the supporting structures of those, so the skin, the nerves, the muscles. Experiencing pain for a long time changes our brain. There's good MRI evidence for how certain centres in your brain will respond to pain signals and learn those pain signals and amplify them. And this occurs at multiple levels throughout your nervous system, sort of from the periphery up. And each patient is individual. Patient comes with their own genetics, epigenetics, environment, social. And thus the medical management that we use needs to involve not only organ-specific treatment, but medications that incorporate all of that pain theory and have how persistent pelvic pain exists. I've tried to sort of take the listeners through tonight how I approach pain with a patient who comes to the consultation with me, and I think it's really important to my animation's going to work. Thank you. Yep. Thank you. Yeah, they're not great animations. They're not great animations. I was like, just to highlight. So I like to break it up into sort of 4 main contributors to persistent pelvic pain. You've got pain from the organs, so pain from the uterus, pain from the cervix, the bladder, pain from the musculoskeletal response to that pain. So we're talking the superficial and the deep pelvic floor muscles, abdominal wall muscles, and that's where the physios took the audience through last month. You've then got the neurological pathways and that central sensitization of the nerve pain pathways, and then the psychological sequelae of persistent pelvic pain and the importance of that. Now, I don't have training in psychology. I haven't done psychiatry since I was a 5th year medical student. So the last part of this talk on that is really quite brief because it's not an area of expertise to me, and I really value the input of our general practitioners, psychologists and psychiatrists in that area. As I said before, multiple pain syndromes can coexist, and this is a recent article by Lamvu and team that looks at the huge array of symptoms that are lumped in with persistent pelvic pain, and you can see the vast array of 10 different structural systems there. It can be very tricky to work out what the true cause of persistent pelvic pain is, and I tend to say actually that's not that smart. I can't always work out what the true cause is, but if I can try and work out the different contributors, I think I'm getting a little bit of the way in terms of helping my patients through those. I like this diagram, and I have this sort of that I can help take patients through in terms of that way that organ pain can cause muscle and skin pain, and that organ pain can cause other organ pain. And that's because of how the nervous system is structured, and that cross-sensitization between organs and between what we call organs or viscera and the somatic system, which is our muscles and nerves. And this is really important when we come to looking at the medical management options for pelvic pain. Thank you for driving this, Kate. All right, so I'm a keep it simple, stupid type person. So I've put a couple of things that I really try and nut down. Periods are rubbish if you're not trying to have a baby, and periods hurt. By and large, there are not many people with a uterus walking around who enjoy their menstrual period. Even if it's not debilitating, it's still unpleasant. When you think about it, periods are pretty traumatic. Yes, they're natural and it's a physiological phenomenon, but I don't really know any other natural event that it's considered to be painful, acceptable to be painful, other than childbirth, and we're not expected to have childbirth every month. Sorry, bad joke, but we're not. And at the end of childbirth, you get a baby, but at the end of the period, you don't get anything other than dirty linen and having to go to the shops and get more sanitary products. 80 to 94% of patients report period pain. A person assigned female at birth is likely to have 450 periods in a lifetime. That's 450 painful episodes. Despite numerous studies, the exact reason why periods hurt is not fully understood. But about 60 years ago, we understood that there are these, I call them toxins, but they're mediators that are called prostaglandins, and they are released each time the endometrium or the lining of the womb sheds, and it's related to a little bit of ischemia, contraction, pain, and the interference of those prostaglandins on other areas of the pelvis, and ultimately they are inflammatory. So periods are a type of inflammatory type pain. Why is endometriosis associated with pain? I'm sorry, I've got one picture that I'll just show you what sort of steps if you take through, but I'll come through that. It sort of gives you an idea of what's happening every time you have a period.
Want to show it now?
Oh, sure, and then we'll have to go back.
Yeah, okay.
But yeah, so the top period just shows it's very much a schematic picture, but it's what happens every month when you when a person with a uterus menstruates. So the lining builds, it gets thick, it becomes unstable, progesterone is taken away and it sheds. And you can see just how traumatic that is at a tissue level, that you've got this structure that's about a centimetre and a half thick, and we denude it down to about 3 millimetres thick. And in the bottom diagram there, that's I think quite a beautiful scientific photograph of what's happening. The little red dots are blood cells, so you can see how magnified that is. And the underlying tissue, the grey beige colour, is sort of the basalis, or the lower end of the endometrium. And this layer is lifting off. You can actually see that denuding off the top of the endometrium. One of the professors I've worked about talks about taking a carrot peeler to your pinky every month, and that's the same surface area. It's traumatic, it's painful, and they're rubbish if you're not trying for a baby. We don't entirely know why endometriosis is associated with pain, but again, it is an inflammatory type tissue that is deposited on serosal surfaces, peritoneum, and the lesions themselves can bleed, but interestingly, not always in time with the menstrual cycle. They can cause acute and chronic inflammation, and they cause fibrosis and distortion. Do the ovaries cause pain? Yes, they do, but in a different sense. Again, ovulation is a trauma. There's actually something rupturing out of a surface. It's not a serosal surface. But I've popped a picture there. Kate's kindly doing my work for me, and you can actually see there's a beautiful picture. It's one of the only times that at laparoscopy we actually visualise, and it wasn't me, but the team about 14 years ago actually witnessed this event in a laparoscopy, the actual oocyte being ovulated. What about the bladder and bowel? So interacted again, that cross reactivity or cross talking between the organs of the pelvis and their response to prostaglandins through menstruation, change in hormones during ovulation, high levels of progesterone, all of that can change their function and change their reception to pain. And the vulva and vagina itself can be viewed as both a skin and a muscle, but also as an organ pain. Now, the reason I've taken you through that, because I know we're meant to be talking about medical management of pelvic floor, but I think we're barking up the wrong tree if we try to medically manage pelvic floor, if we continue to insult the pelvic floor with pain every cycle. We'll probably skip through that one. And that's, again, just a diagrammatic version that shows that prostaglandin release as the last part before and during that menstruation, and that link, or that sort of very simplistic but linked to why periods cause pain. So very briefly, treatment options for the organ pain, menstruation, ovulation. We have the combined pill, and I'm not going to step everyone through each of the individual hormones, but and that says 17, there are now 18 different hormonal combinations of estrogen and progesterone, 40 plus, I think it's 47 different brand names, plus you've got the NuvaRing as well. You've got four, you've got 3 different contraceptive progesterone-only pills, plus Ralavera and Bazane or Bazan, however you want to take it, and then the long-acting reversible contraceptives, Implanon, Mirena, Kylena. I think the data is still limited in terms of pelvic pain treatment, and Depo-Provera. These are the lists. I have these on my desk when I'm seeing patients with pain, in terms of just because one pill didn't suit you doesn't mean we don't have a bunch more, and they're different hormones. They're different estrogens, so we don't have quite as many options. There's only 3, but there's many different progesterones, and they have different side effects, and depending on what you've tried in the past, and what side effects there's still hope that we will find a pill, so long as you don't have other contraindications that may be appropriate. I've put there other pelvic organs. So changes throughout the hormone cycle can trigger pain in different organs. It is very common for patients to report an increase in pain premenstrually or during the luteal phase, as the gut slows down with increased progesterone. As you're leading into those premenstrual days, the bladder can become more painful. There's also thoughts that estrogen itself can have both sensitizing and desensitizing effects. So as you go through the hormonal highs and lows of a natural menstrual cycle, you can become more sensitized or more wound up to that pain. And that is why I think, in terms of part of managing the muscular pain or the other causes for persistent pelvic pain, is trying to stop these insults of menstruation and these insults of ovulation, and attempt wherever safe and possible to exist in more a steady state, rather than having these high progesterone, high and then low estrogen states. There's also this concept of visceral hyperalgesia, which is definitely not an area of expertise for me, but this idea that the viscera itself, like you can have hyperalgesia of muscles, skin, nerves, you can have hyperalgesia of the viscera themselves. And there's a belief that there's some hormonal mediation to this. there's a group led by Thierry Van Kay up in Sydney who focuses very much on the estrogen and the wind-up that can occur with the exogenous estrogen, so the E2 with the ethinyl estradiol pills, and the effect that this can potentially have. There is a group of patients who would say their pain is worse on the pill, and the belief being that this is linked a little bit to the type of estrogen that we use in pills. I'm not sure if the E4 in Nextstellis, or however we say it, is going to be any different. They're advertising that it might be, though we don't know. But it's about trying to work out what is best. Occasionally, what is best is using something that is not a, if you need to stop menstruation and ovulation, using something that doesn't contain the ethinyl estradiol, moving to GnRH analogues, danazol, which we're not able to get so easily at the moment, and using just a tiny amount of it add back so that the menopausal side effects are avoided. And sorry, I haven't moved my slide across, but that's what that's saying there. I use Zoladex quite commonly. Issue is then in terms of access to PBS funding and long-term use of Zoladex, whilst also protecting young people's bones and protecting from troublesome side effects. But I find it really quite helpful, particularly in a flare episode, to buy 6 or 12 months of time with a little bit of add back to really avoid the flare with ovulation and flare with menstruation. Don't forget the humble non-steroidals and paracetamol. So non-steroidals are, in grade 1 evidence, effective for pelvic pain, predominantly tested in dysmenorrhea. It is quite uncommon that a patient won't be able to use NSAIDs with a flare of pain. There's a couple of conditions that it's not appropriate. Some people don't feel that they're effective. Sometimes it is worth testing different non-steroidals, but by and large, there's not one that is superior to others in high-level evidence. Insufficient evidence in terms of using nifedipine. So nifedipine is a calcium channel blocker, but may have some role in contraction-style pains. Same with orphanadrine and buscopan as a visceral crampy type pain, but some patients will report relief. And also cheap. So moving on, if you remember my colourful diagram, moving now on to the musculoskeletal contributions to pain, it's happily becoming more and more recognised that at least 85% of patients with persistent pelvic pain will have some form of muscular dysfunction, muscular myalgia as a contributor to their pain symptoms. This often goes undiagnosed for many, many years. And I say it's happy because it gives some hope for the patient where we haven't found a visual cause. We have a palpable cause, something that we can show them where pain is and what could be triggering it. I've written there in terms of when I'm taking a history, the type of muscle groups that I'm thinking about that describe pain. So the obturator interni exists sort of if you push down behind your groins and behind the anterior spine of your pelvis, you'll feel almost towards that obturator interni. And commonly patients will refer to pain here as my ovary pain. My ovaries hurt every day. Lower stabbing pain radiating into the anterior thigh, but also deep sex pain, and aggravated by movement or prolonged sitting positions, crossing legs, core strengthening work, compared to the levator muscle, where often it'll be a stabbing up high pain, again can have deep sex pain, sometimes some voiding difficulty, poor emptying or constipation. And the superficial muscle pains, more a superficial style pain, can also be related to vulvar vestibulodynia and difficulty with any penetration, tampons, superficial touch. Again, at a simplistic level, this is how I break up some of the treatments that we have for those non-organ based pains. So the first part of the talk has been looking at my bugbear of really trying to nut down those insults, and the second part is, well, what do we do about all these other types of pain, Sam? I'll refer back to this as we go, but this is sort of a summary if you wanted to take it. In terms of looking at musculoskeletal contribution to pelvic pain, I am a bit of a Botox convert. I do see it as life-changing for a select group of patients. I do use baclofen. I will occasionally have a patient who benefits from orphanadrine for flares. Diazepam suppositories I'm a fairly regular prescriber, and I love amitriptyline, and I sort of tried to highlight that through that green coloured box there. Sorry, highlighted. Excellent. So muscle relaxants. So that's looking at your Norgesic or Phenadrin, Buscopan, or oral baclofen. They may help, but there's not much evidence yet, and definitely in the pelvic floor muscular pain evidence we're really lacking. But I think these can be used as part of flare management plans. So such as Norgesic, taking that 3 times a day in the setting of a pain flare for 3 or 4 days might be useful. Botox, so moving on. So we inject Botox similar to people who use Botox to reduce muscle tension that can be related to wrinkles or from headaches. We can use Botox as a temporary paralysis of skeletal muscle, and the thought being that that will reduce the tension myalgia in the pelvic floor muscles. Botulinum toxin, or Botox, is produced by a bacteria. It's one of the most potent neurotoxins found in nature. It's also the most expensive natural substance. Anyone who's had off-label Botox will know that it works by inhibiting the release of, I need it, but haven't had it. Sorry, Kate. Inhibits the release of acetylcholine into the synaptic cleft, so into the joining interaction of the nerves between the nerve and the muscle, therefore inhibiting the contraction of that muscle, decreasing the pain associated with the hypertonic muscles. It takes a little while to work, and it doesn't last forever. I believe it is useless if we don't do this in conjunction with work with our physiotherapists. I've put the little diagram. You can see prior to 2000, didn't look at it for pelvic pain. Now it's becoming one of the more studied treatments for that musculoskeletal cause of pelvic pain. And sorry, Kate, you sort of flick through and it's a bunch of different studies coming up. And variable results, but overall, we are now seeing benefit, and a couple of last systematic reviews done this year are showing some benefit. Graphic picture, I should probably put a disclaimer, but this is from the wonderful Susan Evans group, who described now 7 years ago a technique that allows us both to inject the levator muscles, but also through that transobturator space, being able to inject the obturator interni using EMG stimulus as well. And this is the technique that that I use in my group at Mercy will use, and we're a part of a study group that published this year on using this technique in a pilot group of patients, now uncontrolled. We didn't have a group who had a sham procedure, but was life-changing for a group of patients, and 6 out of the 9 patients who were unable to have penetrative vaginal intercourse were able to have intercourse by 6 months after their treatment. All those patients had intensive physiotherapy though. And this is just highlighting this change in the literature. So remember, prior to 2000, we hadn't looked, prior to 2004, we hadn't looked at Botox for a treatment for pelvic floor muscle pain. And now we are looking at 3 systematic reviews and an RCT that got published this year. Now, it's still variable evidence. You can see Haraldson et al. Didn't find a difference in their reported pain, but a modest improvement in sexual function. But as we're growing the evidence, it looks like in a select group of patients, and I'll say select, that there is a benefit to pelvic floor muscle Botox. In terms of practical points, we still don't know the optimal dose. There's study groups trying to look at this and which type of Botox do we use. I do use an injection map, but again, we don't know whether it's better to just target all the muscles and hopefully we get some benefit, or is it better to target the muscles that are most painful and most tense on clinical examination. We also don't adjust the dose per se based on the tension as measured in an objective way. It's more as a clinical way, but again, studies are being developed to try and look and say, can we draw up a dosing plan for patients? Can we actually look at how much Botox is needed and where? I've put 3 exclamation marks, but should have 30. we need to do this in conjunction with our physio. The Botox will be gone by 6 months. So if we don't use the relaxation that can be achieved with Botox and use that for the manual manipulation, self-management, self-massage, then it's sort of a wasted $500 vial of 100 units. The data would still suggest that contraception is important for about 3 months after having Botox. Again, it's evidence from other specialties, but the current recommendation is still not to conceive within 3 months of having a Botox injection. My patients, I discuss with them the motivation, the importance of motivation for this treatment, because it's attendance at physio can be regular, but it's what you do at home, and if a partner's involved, sort of having them be motivated is aware. In terms of side effects, I like to make my patients really aware that you have to be prepared that things might get worse first. It's quite common for there to be a flare between about 5 and 10 days after an injection. We try to mitigate the initial flare or initial post-operative or post-injection pain by giving a local anaesthetic injection via a pudendal block, and then some local anaesthetic sometimes to the superficial muscles. But I think it's important to be aware that we've got to have a pain flare plan for when you go home.
And is that always done under general anaesthetic?
For the deep muscles, I do it under general anaesthetic. Yeah. For the superficial, so for bulbospongiosis, I will do that in the rooms with a motivated patient with local anaesthetic.
Yes.
Moving on to diazepam, I said at the start I am using these quite a bit. I think the evidence is still lacking, and they are costly and you have to get them compounded. But I think this is an area that to be excited about. So these are intravaginal or rectal diazepam, if intravaginal can't be inserted, can be helpful for specific groups of patients with high tone pelvic floor dysfunction, but we need more and more evidence. I have seen significant improvement in pelvic pain and sex pain, but again, the literature is divisive on this still. And our physiotherapy colleagues are reporting reduced tone and muscular sensitivity on digital examination. Diazepam works by both primary nerve effects, so reduction in the excitation of GABA neurotransmitter, but also a potential local anaesthetic effect. It also has an anxiolytic effect. Now, the diazepam will absorb systemically as a result of suppository, but absorbs more slowly and not quite to as high a dose. But because of the more slow administration, if you're taking it more than twice a day, then you can actually build up to the same level as if you were taking it orally. We use it primarily for disorders of hypertonicity or increased tone of the pelvic floor and actual palpable contraction, but it may also be useful superficially for vulvodynia because of that local anaesthetic effect. Popped a couple of my sort of practice points if people are interested. Again, we don't know the dose. I tend to use 5 milligrams. I will go up to TDS in some patients, but most of the time it's just a single daily dose, depending on what the daytime activities. I've discussed sort of that pharmacokinetics there. I don't use this as an everyday. I use it either in flare management around the time of surgery or procedures. I do have some patients who will use it pre-coitally, but again, not really sure how to best guide in terms of timing. And a lot of patients will use it prior to going to physiotherapy. Try to get people to avoid using or binge drinking while using it. I don't use many opiates. And I don't like the interaction potential between opiates and benzodiazepines. And I do have some patients who will use it every night long term, and that has become what works for them. We compound it in a fatty base. It is expensive. So compounding medicine, even though Valium, etc., Valium itself is a cheap medication, the compounding becomes the more expensive part. It's messy, but it is very much accessible here in Melbourne, and I have sort of a list of compounding pharmacies throughout Victoria as well who are happy to make these. Mm-hmm. Baclofen. I'm probably a late uptake of baclofen. Baclofen's been used longer than vaginal diazepam. Can be used for both pelvic floor tension pain as a muscle relaxant, but also for its local anaesthetic effects in vestibulodynia. It's often not used alone. My patients who use it or come to me using alone are often patients with sort of spastic hemiparesis as a result of cerebral palsy. It can also be compounded as a vaginal suppository, and I'll sometimes use that in conjunction with diazepam. There is a study currently recruiting and ongoing. I'd be interested to see what the outcomes. So what I'm doing at the moment is largely evidence-free. There is some look at using this as a topical compounded cream, so mixing it in with some Endep, or excitingly with some PEA, showing some benefit in terms of sensitisation of the vulval tissues. So that's sort of a step through the musculoskeletal options, and now moving on to the neurological and neurosensitization. Now you'll see I've tried to kind of smarten it up with the Venn diagram. Maths wasn't my strong suit, but essentially you've got some medications that work on multiple contributors to that persistent pelvic pain. So you'll see that still Botox is in there because it may affect those neurotransmitters. Baclofen does. It has an anti or an analgesic effect. And then I'll list through some of those others, but we've already covered the first two there. So once a pain of any kind is present on most days, there is some central sensitization at play. The brain actually changes and it upregulates your pain perception to what's going on, but also to other potential pains. You know that if you have a headache and you stub your toe, you deal less well with a stubbed toe. And it's that sensation that the nervous system just doesn't like all these insults coming on. I think it was last year, Amelia Ryan and her team at the Women's published a paper, a nice little paper in the Australian Journal that showed that for patients presenting with persistent pelvic pain, 3/4 of them had clinically significant elevated on a central sensitisation inventory. These patients were 5 times more likely to have had their pain long term, and 10 times more likely to suffer bladder pain, almost 10 times more likely to have IBS symptoms, and many of them had mental health diagnoses and vestibular vulvodynia. For those of you working clinically, I find this quite a useful tool to explain that, and I use this for patients either indirectly and sort of step through, or actually print it out, particularly part A, and just show how all of these symptoms can make sense if we talk about the neurological system. So where do the medical options fit with neurosensitization, central sensitization? So taking you back to the organ pain to start with, we must reduce the insults. The more insults you get, the sort of increased wind up of your pain. I presented a paper last month looking at the reduction in sex pain and daily pain you got if you had more time between your periods. So if you had a Mirena put in and you hadn't had a period for 6 months, we hadn't operated on you, you just had a Mirena, your actual other pain started getting better. I didn't ask about headaches. I'd be interested to know. A nice question someone asked in the audience, did headaches get better? Maybe, and probably I should go back and ask. But it's that idea of avoid the insults to start with. Be aware of what triggers. So be aware of events, stressors, constipation, bladder infection, and try to mitigate, to avoid those triggers if we can. Have a daily management. So and this is what I'll step you through now, what baseline medications can we have to down-regulate these painful sensations, and what can we do when the flares take place? So baseline management and what happens when pain triggers occur and we have painful episodes. I was like, am I going badly for time, or have we got questions?
You're going perfectly, and I'm really enjoying this talk.
I'm ravaging on.
And you have permission to have a sip of water if you want one. I'm looping back because we have time, because it's probably the right time. There was a question from a physiotherapy in the audience who says, what are your thoughts on patients using oral Valium vaginally?
Yeah. Thank you for the question. And we've explored this a little bit, not in study data, but an anecdata, because in the public system, when a patient comes in with a flare of pain, we don't have them sitting in the fridge to give vaginal or rectal Valium. I do use it. I think the issue is at an absorption level, because the tablet's designed to be absorbed in the stomach, so in a high acid environment, and the stomach acid is sort of pH 2, whereas the vagina is sitting at somewhere hopefully between a pH of 6.5 and 7 and a bit, and that idea being that the absorption in the probably what is helpful, and also at a sustained release. But I don't think actually a pharmacokinetic, I'm not aware of it all, but that's sort of what goes on in my head. And a couple of patients I've used it, I think it probably treated me more than it treated the patient, because I felt like I was doing something that might be helpful.
Yeah. There's one other question which is also looping back before we continue forward, which says, with pelvic floor physiotherapy, is 19 years too old or too young to consider after recently being diagnosed with stage 4 endometriosis?
Say that again, sir.
Is 19 too young to start pelvic floor physio? This patient has just been diagnosed with stage 4 endo.
Sure.
She's 19.
Absolutely not. So I think good pelvic floor health, regardless of what your diagnosis is of the initial pelvic condition, pelvic pathology, if at least 85% of patients with persistent pelvic pain have a muscular component, then at least that of endometriosis pain will as well. And I think we can do the best surgery for grade 4 endometriosis. And if we miss the muscle pain, you may not be any better. Your periods may be better, but the day-to-day pain, bowel management, bladder management may not be treated by removing all the visible disease.
Yeah. Excellent answer. Another question has just come through, hot off the press. We're seeing a lot more use of amitriptyline topically for vestibulodynia, and then less sensitivity having a positive response on muscle tension. Would you recommend it on its own or more compounded with other medications? That's also from a physiotherapist.
Wonderful. Yeah. I'll come to amitriptyline being my star medication, but I usually start medications in a single form. Just because of if you compound things together or you're mixing different agents and someone has a side effect that you're not really sure what is the cause of the side effect and what's useful or not, and I guess just a cost level for the patient too. So I love amitriptyline, and I'll step you through the 3 different ways that I tend to give it. But I think the question was, do I always put it with something else? Or I would often try it on its own to start with, and then if we're getting no effect, then switching something completely. If we're getting some effect, and definitely a physiotherapist calls me and saying, hey, we're getting somewhere, but we're not able to bump up dose if we're using oral because of side effects, or what are your thoughts on trying something else? Then definitely adding if we're getting some effect, but not all the way there.
All right, let's keep moving forward with this topic if everyone's happy.
I don't know whether to talk to you. I should be talking to you rather than talking to the screen. There you go. Oh my gosh, yeah. Call card for amitriptyline. Now, I'm going to highlight it. Do you want to press one more? Yeah. Oh no, go back. Anyway, it was meant to highlight that amitriptyline is the only medication in the middle of the box. And that's because I think it's the only one that actually addresses all of those additional 3 contributors to persistent pelvic pain. I think it's one of the most useful medications we have. Anyway, it's just because my slide's a bit stuffy. I only have to give it to 2 patients for 1 patient to tell me it's helpful. That is the best medication that we have in terms of number needed to treat. So if you look at opiates, it's somewhere in the realm of 1 in 12 will get a benefit, and actually over time 0 out of 12 will get a benefit. If you're looking more at some of the other medications we've gone through, or some will come to, it's more sitting at sort of 1 in 6 to 1 in 8. So I think amitriptyline, if well tolerated, is very happy medication. It can help with multiple pain symptoms because of that interactivity between the organs in the pelvis in terms of them living very close to each other, but also due to those neuronal components linking everything. It's very good for sharp or burning pain. It's great for overactive bladder or painful bladder syndrome. It can help with IBS, and I've just put a caveat there because I had a nice discussion with a gastroenterologist the other day in terms of sometimes it makes slow transit IBS or gastroparesis type illnesses worse because of the anticholinergic effects in the bowel. So just someone who's very constipated as a main symptom of their pain, I may not jump to it as my go-to. The physio one who mentioned, I use this very commonly as a topical agent in vulvodynia. Some of my patients will just say everything just feels on fire or on in my pelvis, and I think for that sensitization where they can't localize what's hurting, it's just everything feels uncomfortable. I think it's a really good systemic agent. It's also helpful for back pain, headaches, shoulder aches, sleeplessness, and it works by modulating the way that the nerve interacts at the neuromuscular junction by increasing, and sorry, I put the American there, not norepinephrine, but in terms of increasing the neurotransmitter availability, increasing the serotonin, and reduces pain sensitivity. Now my practice point, so this is focusing on oral use, and I'll step you through topical and suppository use as well. The main reason people stop amitriptyline or Endep is because of side effects. So start low and increase very, very slowly, even if it's taking you 6 to 8 weeks to reach a therapeutic level. I tend to, in a patient of normal BMI, aim for about 25, sometimes up to 30. And I'll have the occasional patient who is on 50, but most of the time they're on 50 for headaches or neck pain. Tablets come in 10, 25s and 50s. You get 50 of them in a prescription, you can get a couple of repeats. So I step patients through in terms of how to increase that with time, get a pill cutter, and sort of how we can adjust that prescription. Take it about 3 hours before going to bed, and if you're waking up tired in the morning, bring it forward. Not great for shift workers in that regard, so sometimes we use other agents that have less association with sleepiness, and doesn't work straight away. So I think it's hard when you're kind of increasing a dose or you're trialing a medication. You've got to give it time to work, and you'll see with a lot of these medications they do take time. Dry eyes, dry mouth, constipation, sleepiness, fatigue. Some of those symptoms will settle with time, and so sometimes we'll manage the dry eyes, dry mouth for a couple of weeks and just see if it actually settles with time. In terms of side effects, if they're a problem, I'll often drop back by 5 milligrams and then increase even more slowly if the patient's motivated to give it a try. And it's not evidence-based, but I have a couple of patients that come to mind that we have switched to nortriptyline, and then the side effects that they're having, particularly the sleepiness, seemed to be less of a problem. Yeah.
Interesting, yeah.
Don't stop suddenly, so it's not working for you, or you're finding you're having another reason to cease. Wean it down almost as slowly as how you took up. So if you're on 30 milligrams, taking at least a month to come down from that dose. And I've put there consider contraception. When I went through ONG training, it was, absolutely contraception. I work in both obstetrics and gynaecology. I have a couple of patients on low dose amitriptyline, and with an open discussion, they've elected to continue on their low dose amitriptyline into pregnancy. So I think it's worth an open discussion with fertility providers, GP and obstetrician. I've put there, so topical application is really common, and I think the evidence is quite supportive. We use this in a sort of a percentage range. I tend to stick to 2 to 5% compounded, but can use higher. Have gone up to 10%, and it's still being well tolerated. Often in an organogel or a neutral base, and there is a commercially available product made by the team in Sydney that combines estradiol and amitriptyline. They're lower doses, as you can see, so the Endep is in 0.5% and the estradiol is similar to Ovestin, but good efficacy data there for sex pain and improvement with general sitting on sitting in a chair. Now that is a study done by the team that has disclosed that they have financial interest in producing my gel, but really good, promising data. And that's sort of what I'm seeing at a patient level. About 2/3 of patients find it beneficial. And then just going into the other things that you can compound it with, particularly if you're looking for superficial muscle relaxation or that additional local anaesthetic effect of baclofen. And amitriptyline, in essence, is a low dose, sort of a low potency local anaesthetic, and that's sort of the way it's working at those tissues. I have, for a couple of patients, and I've put there totally evidence-free, I have trialled compounding as a pessary, intravaginal, or for one patient rectal amitriptyline, with an alteration in their side effects, and I can't explain that completely. I've tried to look at the pharmacologicals or the pharmacokinetics, but they wanted to give it a try. They were suffering particularly with the anticholinergic effects from the swing in dose of oral absorption, and we're able to stay at a lower dose and have some effect with intravaginal, but I don't know many people who do it, and I don't know whether it's the right thing to do. So I've put there in terms of, I think, watch this space.
Yep. Happy, yep.
Yeah, thank you. Sorry. I've popped there duloxetine and also venlafaxine as an SNRI. So the analgesic, I have my water, sorry. 2 seconds. The analgesic effect of antidepressants is primarily achieved through the increase in descending inhibitory tone and a decrease in the ascending pain receptors that go up to the uterus. It's most commonly achieved by increasing the norepinephrine available within the brain, and that's where the SNRIs come in. In general, patients with depression and pain can benefit from the increase in both serotonin and norepinephrine that's seen with the medications, and patients with chronic pain alone without the mood disorder, it's the norepinephrine that's doing the work. I find these very helpful for patients who don't tolerate amitriptyline. So amitriptyline is often my first line, and then I'll move to duloxetine as a second line, or for patients who come with an anxiety disorder that is unmanaged. I'll discuss with their GP or their psychologist in terms of the role of potentially addressing two problems. In terms of practice points, duloxetine should be taken in the morning, 30 to 60 milligrams per day. Sometimes I'll start slower, and you can do that by tipping out. I think on Pelvic Pain Foundation website, there's a good sort of instructions on how to count out the granules and to adjust that dosing.
Wow.
Venlafaxine, I start really low. So these come as 75 milligram tablets. I halve, capsules, and I halve them again, removing granules. And they're superior to using SSRIs. So for patients who turn up who are on an SSRI, who have considerable pelvic floor, persistent pelvic pain with a sensitization component, I think it's worth us as gynaecologists discussing with general practitioners, psychiatrists, the potential safety of switching. Now, there are lots of nuances to the choice of medications used for anxiety and depression, and I'm not across them, so I don't advise the switch with the patient without discussing it with the prescriber, but a lot of the time actually an SNRI is appropriate. It's just then about having the guide about switching between the two medications. I don't combine duloxetine with amitriptyline. You can combine duloxetine with gabapentin or pregabalin, so that's the other benefit as well, in terms of not risking that serotonin side effects.
I'm going to go on to the next screen, but I'm going to interrupt you. We've got several questions. There's a person in the group who's 26. She's wondering if it's too young to start Botox for dyspareunia. Is there any long-term effects, negative effects using it long-term, and can it have negative effects for PCOS?
Good questions. I'll start with the first question in terms of age. No, I don't think you are too young at 26 to have benefit from Botox. And I don't think age should be a precluder. In terms of the second part of the question, negative effects long term, there's a study that has was a few years ago now from Erin Nesbitt Hawes up in Sydney that looked at repeated doses of Botox. So there is benefit, cumulative benefit of receiving a second dose. The most I've ever done for a patient is 3. And the reasons around that in terms of Botox is I think if you don't get any benefit, despite Botox and good physiotherapy, so long as the technique has been adequate, I don't think there's a role for a second dose. If you get some benefit and it wears off, then I think there's a role, and it may be that you get improved benefit with the second dose. But I think that's where it comes into in terms of it's only as good as the physio work that we do with it because of the way it works. So I think long-term effects of multiple doses, we don't know because most of the time it's not more than 2 or 3, but with those cumulative doses, no, there's not been an increased incidence of adverse side effects. But I think you really have to look at what benefit you got with that first dose.
And is there any negative effects for PCOS?
Not that I know of.
Excellent. Another question, is the vaginal suppository an idea for pain when having a flare? Would it help with an overactive and tight pelvic floor?
If you're referring to the...
I'm not sure.
Diazepam suppositories, yes, I do use those in the setting of a flare. Endep suppositories, no, I use those as a sort of a baseline chronic daily pain management, and I've only used those, as I said, very select group of people, because usually we would give it either systemically, so taken orally, or as a local anaesthetic cream.
Fabulous. And last question before we move on to the final 10 minutes of the presentation.
Sorry. I told you I wouldn't keep to time, Eliza. I'm really sorry.
Someone is asking that they've been prescribed TGA-approved cannabis oil for pain. Do you have any experience or recommendation regarding that? I don't know if you move on.
Can I delay that till later?
Oh my goodness, onto opiates. All of us.
Now, I've changed the colour slide there just to highlight that this is not a main part of my armamentarium. So narcotics, so I'll lump codeine, so that's codeine, panadine, fort, methindol, fort, oxycodone, morphine-based, tramadol, taventadol. They're all part of a group of medications that are good for short-term pain. They are good for post-operative pain for a couple of days. They're not good in terms of long-term persistent pelvic pain. When used regularly, I've taken this directly from Susan Evans' team. I do apologise if Susan's on the line. When used regularly, there's a few things that happen. Do not work as well. Our bodies get used to them, and you need longer and longer. For those of you on the line who hasn't watched the Big Pharma Dope Sick, it is incredibly frightening, but incredibly eye-opening to the problems that opiates are. We don't have as big a problem as the US, but we will go that way if we don't do something about it. They don't work as well. They worsen pain. Worsen pain. They might help when a flare takes place, but then over time, used day to day, they actually increase that sensitization. They are addictive. They change how we think. There's actually really good functional MRI data that shows the changes in how our brain works with long-term opiates, and they're dangerous. They can stop your breathing. They lead to drug overdoses, and the ones that we prescribe as doctors are more dangerous because of the larger numbers. And the use is than the street drugs that we all grew up worrying about. They also have other side effects. They make you constipated. They can affect how your bladder works. They make you nauseous. You don't function as well at work. So I've put them in. They have a role for acute post-surgical pain. Occasionally, they will be used in sort of day one of a menstrual period, but go back to the slides at the start. Let's try and avoid the menstrual periods to start with. And they are given in emergency departments for acute pain flares, but I think we need to do the best we can with all the other medications for our flares. Sorry, that's my soapbox. I'll get down now. Pregabalin and gabapentin. These medications belong to a group of meds that we refer to as anticonvulsants, and they work as calcium channel blockers, decreasing the reuptake of glutamate, norepinephrine, which you'll remember from the other medications. They're originally designed for seizure disorders like epilepsy, but actually they're less commonly used for those conditions now, and we more commonly see them in pain management. They essentially reduce the hyperexcitation of nerves. So again, in those up-down nerve pathways that you saw in the diagram 45 minutes ago, I'm sorry, they affect the way that the brain receives the message of pain and how it dumbs it down, going back down. They're really good for nerve pains, stabbing, sharp, burning sensations. Now I've put there's a recent paper out a year and a half ago that actually indicates gabapentin was not useful so their conclusion is that it wasn't useful for persistent pelvic pain and comes with a risk of side effects. But if you read the paper, they actually did observe improvements in sexual function in the group that had pelvic floor muscle pain. And I think if you look at pelvic floor muscle pain and what sensitization is going on, and you use a sort of an individualized approach, then I think there still is a role. And yeah, we'll go on to the practice points. So I tend to use gabapentin before gabapentin before pregabalin, just because it's cheaper. Both of them are less likely to cause sleepiness. And so I'll commonly switch or try gabapentin if ENDEP is not tolerated. So depending on what the group of symptoms are, I'll make a decision after ENDEP as to whether we go down duloxetine or gabapentin. Weight gain is a real side effect on these medications, and that can be quite confronting when they discuss sort of some risks with patients. Not recommended in pregnancy, can be used with ENDEP or duloxetine because serotonin syndrome is not an increased risk. And again, don't stop them suddenly. With pregabalin and with gabapentin, we start slowly. So starting at night, getting over the initial uptake and potential tiredness or dizziness that can occur, and then gradually increasing to BDE dosing. Some patients are fine on nighttime dosing only, and if we reach a dose at a higher level at night that's effective, don't add in the daytime dose. You can, so Lyrica, pregabalin, we can use in the setting of an acute pain flare, and some people will reserve their morning dose or sort of just take a nighttime dose and take an extra dose if they're having a flare.
We have a question from someone in the group saying, can amitriptyline be combined with pregabalin, or would you stick with duloxetine if the patient is already on pregabalin? That's a tongue twister.
I'm just going to read it, sorry. Amitriptyline be combined? Sure. If you're already on pregabalin, yes, you can add in amitriptyline. If you're getting benefit from both duloxetine and gabapentin, then I wouldn't think you need to switch. You just can't use the duloxetine. Well, there is a risk if you combined duloxetine with the ENDEP. So if you're trying to look at it as a sort of a triangulated effect, and there's no role for putting gabapentin with pregabalin, I don't think. I think you've got to choose something in that class.
One or the other. Yeah.
I do use topical gabapentin. I don't know if other gynaecologists on the webinar see as much benefit. I usually combine it with something else, so it's usually as an additive rather than using it as an alone, or if someone has had significant anticholinergic side effects from ENDEP, which are less common with topical, but I do see it as a useful medication. Study's quite old, but compounded in a lipoderm cream applied nightly for vulvodynia saw a 50% improvement in pain scores, and it was a very small study, but 6 of 9 patients reinstituted intercourse. Again, compounding it goes from a cheap medication to a more expensive medication.
You all get a free degree in pharmacology tonight for listening.
CBD books. Sorry, I'm not a pharmacist. If there's any pharmacists on the line, maybe you can give me a free tute too. I've popped local anaesthetics there. I have a couple of patients who will use local anaesthetics regularly in the setting of flares or before physio or other interventions. Used to be the first line treatment for vulvodynia, but then about 20 years ago there was an RCT that showed no benefit in the long-term management of vulvodynia. For those whose vulvodynia flares in the setting of viral reactivation, HSV, occasionally with a thrush flare, I think there's a role, but otherwise I don't use it that commonly. For abdominal wall syndrome, it hasn't been studied yet, but there are some clinicians who feel that local anaesthetic patches, of which I think there's only 1 or 2 brands in Australia, are quite useful for those abdominal wall pains. I haven't used it much. That doesn't mean it doesn't work. I just haven't grabbed for it that much. But I think that's something to think at the back of your mind, that these are available. Can be quite helpful for post-incision pain, sort of, a month, 6 weeks after laparoscopy or laparotomy, if along with return to movement, obviously excluding hernias and whatnot, using a patch on that side overlying the area. I don't think it's going to cause harm other than potential. Moving on, sorry. Capsaicin. I'm going to divulge. I've never used it, but in a very select minority, I think it is something that we as clinicians can keep in the back of our heads. It is painful to apply. I've heard of clinicians trying it on themselves just so that they can understand. You don't want to move once it's put on. Often you'll want a fan. So sort of getting set up and expectations need to be managed. And yeah, I think that's probably all I'll say there, just because it's not something that I'm very used to, but if people are interested, there's some good descriptions of how to do it there on the Pelvic Pain Foundation website. I got asked when I was writing the talk to touch on naloxone. Again, not something that has any evidence in persistent pelvic pain, but it's about that opiate sparing type picture, but also potential mood benefits and a mixture with how it relates to nervous system and psychological pain as well. So psychological and some pain. Here we go. Sorry, the cannabinoids. I'm not a THC or CBD oil sort of recognised prescriber, so I guess I come at it from the side of it. It is I will often be involving another clinician to guide me on this. The current Canadian guidelines have come out, I think just last year, saying that we need to be a little bit reserved in our use of cannabinoids just until we have more evidence. But I recognise that there are patients who do report that it is one of the only things that work for them. The recent article in JMIG says we also have to be quite aware of the potential for harm. But sort of cross to that is there's a lot of patients who will be using these medications without prescription in regular settings. So I think we as practitioners need to better understand the role of the cannabinoids in the sensitisation and pain alteration pathways. So at this stage, limited evidence, and we're talking both THC and CBD, but I think a potential treatment candidate that we can look at, and if we're extrapolating evidence from other pain symptoms, yes, maybe there's a role.
There's a lot of research at the moment in cannabinoids, CBD and THC for pain through the Sydney group, and at JACE we're also studying a study relating to that. So hoping to add to that body of evidence, because we know people are interested in it and we know people use it on and off prescription. So we're interested to see if it can be found to be helpful. And
PEA actually, so I only heard of PEA about 2.5 years ago, and I still can't say the actual, it's a 24-letter word, but it's a naturally occurring food compound that has anti-inflammatory and pain-mediating effect via cannabinoid receptors. So this is something that can be bought. We still write a prescription. It's a 3 times daily dosing, which can be tricky to keep, and it takes about 6 to 8 weeks if you're going to see treatment benefits. But it's thought to act by both a neuromodulatory and a anti-inflammatory effect, and also can be compounded. I don't use N-acetylcysteine, but and the evidence I'm aware of is not so supportive. Mickey just asked me to touch on it there. There was a Journal of Pain Medicine systematic review, small, 800 patients, did include 2 studies on endometriosis. I think one study had about 80 patients in it, but overall poor quality data and no benefit seen. That doesn't mean there is no benefit, just means we haven't got study evidence of it. It's not something that I've reached for. I said I'm not a psychologist and don't profess to know much about the nuances of managing the psychological impact of persistent pelvic pain, other than as a gynaecologist recognising the very important role it plays. So pain affects mood and mood affects pain. Mood disturbances can predispose us to pain, but they're not usually the primary cause of persistent pelvic pain. And I think it's really about, as gynecologists and people who are looking after patients with persistent pelvic pain, is not making people feel that it's all because of their mood disorder that they have pain. It's the mood disorder and the interaction it has with the pain. I've done some work on catastrophization. I think that's an important facet of persistent pelvic pain, how we appreciate the pain, what that pain means to us, how we magnify, ruminate and feel helpless because of it. And that's all I'll probably say on to that last sphere of psychological. And thank you for listening to my verbose description of what I think we have in our box of tricks for medical management of persistent pelvic pain. I hope that that gives some hope to both patients and clinicians and the loved ones of patients. I encourage people to use an individualised approach. And I think with working with all patients, we need to have very clear treatment aims. And that comes from an open discussion. What is possible? What are we aiming for? Symptom relief, restoring function and improving quality of life. And if we can look at those, you can sort of see where all those treatments come in.
Amazing.
And sorry, these are my notes and a couple of questions that Nikki went through, but you can.
There are no new questions from the chat other than a picture of Nikki's dog, who I'm sure we all wish Nikki could be here this evening, but she unfortunately cannot. So that's all the questions relevant to the talk from that group. So if we've got time, Eliza, what's the time check? Okay, we'll do one of Sam's questions and then we'll wait for some more questions in the chat and then we'll close the session. So which one of these?
Oh, I don't mind.
Maybe just the first one.
Yeah, sure. Yep. So I think prior to the meeting, a message went through to Nikki in terms of what can we do if the physio itself is one of those triggers for pain, and I'd be interested if the physios want to put up on there what they've seen work. So I think using very simple analgesia, paracetamol, non-steroidals prior to pain may affect with any of those organ pressure points. I think that is definitely a role for having a baseline pain medication that works at both a neuromuscular level and a muscular level. So that's where that NDEP comes in. And potentially, as I said, I've got a couple of patients who will use diazepam prior to their physio, probably at least an hour before. And I think that's potentially where Botox could have a role. That I've had a couple of patients who were unable to do any internal treatments with their physiotherapists until they'd had Botox. Now, I'm not saying that everyone in the audience needs to go out and have Botox, but just as so that can be the change that is seen.
Correct. There's one comment, and I'm sorry I can't see who it's from, but the comment says NAC doesn't help the pain, but is effective with endometriosis and could improve pain. So it's, I think, just a comment from someone in the audience who wanted to share
potentially an anti-inflammatory point.
Result. Yeah. Excellent. So we're going to wrap up in the interest of time, and everyone's been so committed and staying online listening to this wonderful presentation. We've looked at all your questions. I'd like to pass on the gratitude on behalf of myself, Nikki, the rest of Jace and the rest of the endo community, Sam, for obviously the massive amount of work that she's done in preparing the presentation for this evening, and the massive amount of work she does in caring for patients and being affiliated with our centre. I'd encourage more people to send through questions if you've got them, and also if you'd like to contact Nikki either to have a chat about your clinical care or for any other concerns, her details are there, email or telephone call. And we look forward to welcoming you to the next available webinar. Very good. Good night.
Thanks, everyone.